Great. So thank you for the introduction. You know, I'm actually very pleased to be here, and I'd like to thank the organizers for inviting me to talk on how to evaluate the response to immune checkpoint inhibitors. You know, I'm a melanoma oncologist, just as it was said at the Tom Baker. I treat melanoma, so it's actually great that I'm here at the Gyne group because ultimately it tells you about the revolution about immune checkpoint inhibition because it's being applied to a whole slew of cancers. And, you know, I titled this talk, Know When to Hold Them, Know When to Fold Them, because it is a bit of a gamble to know when to stop the treatment or continue the treatment in the context of progressing disease. These are my disclosures. And these are the objectives. You know, today I'm going to be defining the unique characteristics of immune checkpoint inhibition and part the unique response kinetics that we observe with it. We're going to look at the evaluation of the response to immune checkpoint therapy using response criteria that are novel and have been proposed. There's several of them that have been proposed. We're going to integrate or identify applicable gynecological cancers for immune checkpoint inhibition. So before I get into that, I think most of you guys know about this, but essentially I'm going to talk about some of the mechanisms of action of these immune checkpoint inhibitors. You know, in the context of an anti-cancer immune response, you want your T cells to be active towards the cancer. And there are certain mechanisms to turn off your cancer. In the context of an anti-tumor response with your immune system, some of the immune cells, one of the normal mechanisms to turn off your immune system is to express CTLA-4 on its T cell surface. It interacts and competitively inhibits the binding of CD28 to B7. It binds to B7 and turns off your T cell. You don't want your T cell to be turned off in the context of, again, the anti-cancer response. And so ipilimumab was developed to inhibit this interaction so it potentiates your T cell response to your cancer. This occurs in the priming phase early on in the immune response, and it occurs in the spleen and lymph nodes. Now, another mechanism to turn off your immune system, which we don't want happening, is that the tumor hijacks this mechanism of expressing PD-L1 on its cell surface. And PD-L1, when it interacts with its receptor PD-1 on the T cell, it actually turns off your T cell. Again, you don't want that to happen, and so antibodies like pembrolizumab, nivolumab, atezolizumab have been developed to inhibit this interaction. This occurs in the peripheral tissue and also in the tumor microenvironment. And so because it occurs in the tumor microenvironment, what we notice is that these drugs actually have a quicker, more specific response because it's looking at or acting on the T cells that are already within the tumor microenvironment. Moreover, it also results in less toxicity because of the specificity of the response. So this brings us to the unique response kinetics that we observe with these immune therapies. So we see these unique kinetics in part because of the mechanism of action. It's not the drug that's actually killing the cancer cells. It's the drug's activation of our immune system to unmask the cancer so that our immune system can recognize it. That's why we see what we call pseudo-progression or delayed responses. So I just want you to, sorry, I know I'm focusing on the right side here, but this is what we call a spider plot, and each of these lines represent a patient's response to treatment. If it drops below 0, it means that you're responding. If it goes above 0, your tumors are growing. And if you look here, a lot of people are actually having responses, and they're durable, lasting over 120 weeks. Some have stability of their disease, but this one is the one I want you to focus on. There's an individual here where their disease from get-go actually started to grow, and then only at about 40 weeks, there was a drop and shrinkage of their disease. And so this is what we call pseudoprogression or a late responder. The other interesting thing is that these triangles represent the first occurrence of new lesions. Sometimes we see new lesions develop in these patients that have ultimately overall tumor burden of shrinkage. And so you see them, some of them actually had shrinkage, some of them had growth, but we sometimes see first occurrence of new lesions in these patients that don't necessarily represent progressive disease. So this is an example of a clinical pseudoprogression. So here's a patient here that had severe cutaneous mets at baseline, was treated with ipilimumab, and after 4 weeks, it actually looked like their disease flared. The thing is that this initial increase ultimately pushed this patient off the study because he was deemed progressive based off modified World Health Organization criteria. But then ultimately by 16 weeks, he developed a response, and then at 96 weeks, he has an ongoing response. Apparently, this is one of the first patients that was ever treated with ipilimumab. He's still alive today, over years later. So here's another example of pseudoprogression with new sites of disease, not just progression of target lesions, but this liver looks relatively clear. There's maybe some small distils of cancer or tumors within the liver. But you can see here after 4 weeks, there's definitely new target lesions that have developed. And then subsequently, on ongoing imaging, they start shrinking down and ultimately disappearing. So not only can you see progression of target lesions, but also new lesions can be observed. So why do we observe these unique kinetics? One, it's either that there's true increase in their tumor size and it's just a delayed response, or the other alternative explanation is that there's pseudo changes that lead to the appearance of an increased tumor size on imaging, such as immune cell infiltration or edema. There have been biopsies of this where people have had pseudoprogression, they biopsy the tumor, and ultimately all they see is T-cell infiltration with no evidence of cancer. So ultimately, this brings us to why do we need immune-specific response criteria then? So one, the data suggests that overall survival is not reflected in progression-free survival or the objective response rate using traditional response criteria solely due to these atypical responses we are observing. And it's also important to have a specific response criteria for the immune system is to better describe the response kinetics and also to have consistency amongst clinical trials. There might also be benefit in the context of helping us answer clinical questions about what's the best duration of treatment and also treatment beyond progression. So this just brings up that it's not necessarily, these atypical responses aren't necessarily reflected in overall survival with traditional response criteria. So this study was actually looking at non-small cell lung cancer and PD-1, PD-L1 inhibition in several clinical trials. And what they did was they retrospectively looked at the patients that had atypical responses, such as the pseudoprogression or alternatively discordant responses where some sites were shrinking but some sites were growing. And when they lumped in these atypical responses and looked at their survival is very similar to those patients that actually had stable disease, classical stable disease, partial responses or complete responses. And it was superior, their survival is definitely superior to those that had progressive disease as per classical criteria. And this was just published in the European Journal of Cancer in 2018. So the first question I have is, how many immune-specific response criteria have been created? I'll give you a hint. Typically, we use modified World Health Organization or RECIST in clinical trials, so there's at least probably 2 that they based it off of. Oh, wow. I didn't think it would be this accurate. So, yes.
Okay.
You know,
the answers are still coming in.
Okay, fair enough. Well, the answer is 4. And 4 is what I could find anyway.
Okay.
And so, the first one was actually based off the Modified World Health Organization, and this was published in 2009. This is the Immune-Related Response Criteria, or IRRC. There's also other ones that are based off RECIST, so the vast majority of them are actually based off RECIST response criteria. One of the most recent one was actually this one published in JCO at 2018. This was in several lung cancer and urothelial trials of atezolizumab, a PD-L1 inhibitor. Now this one is actually from Leslie Seymour at the CCTG with the RECIST working group. And again, this was published just recently, Lancet Oncology in 2017, with the backbone being RECIST 1.1. There's some similarities between all of them, and this is what I'm going to go over now. One, all of them suggest that new lesions and growth of lesions don't necessarily represent progressive disease. The second is that new lesions are added to the total tumor burden measurements, and they reflect progression or response. All suggest a confirmatory scan after 4 or more weeks if progression of disease is suspected. So this is the consistency between most of them. There are a lot of differences, but I'll just give you some examples to some of the changes. So again, using the immune-related response criteria based off of the modified World Health Organization response criteria. Usually if you have new measurable disease or new non-measurable disease, it always represents progression. But in this context, new measurable disease is incorporated into the tumor burden, and new non-measurable disease does not define progression, but it has to completely disappear if you want to have a complete response. Non-index lesions, again, contribute to the best objective response, but it doesn't contribute to IR-CR in the immune-related response criteria. And just to hammer the point home, so again, with immune-related response criteria, immune-related complete response, all lesions have to disappear. But this is where the change is. IR and immune-related partial response, 50% or greater decrease in the sum of the lesions in the perpendicular diameters of the index lesions and new lesions, but the detection of new lesions would be allowed, so would be allowed. If you had progression of your disease, immune-related progressive disease, 25% or greater increase in the sum of the perpendicular diameter of the index and new lesions, and IR stable disease is all other patients. Now, these numbers might not be that new to you, a bit novel to you, because modified World Health Organization used bidimensional, so 2 measurements, while RESIST usually only uses unidimensional. There's actually a study that demonstrates that unidimensional is more consistent and more accurate in terms of consistent measuring, and it's obviously simpler. So, I like the unidimensional, but I just give examples here about the modified World Health. So moving on to the RESIST, again, similarly, if you have new or non-measurable disease, classical RESIST always represented progression. But in any of the immune-related RESIST criteria, IR RESIST, I RESIST, or IM RESIST, it also is incorporated into the tumor burden as a whole. Now, non-measurable disease, new non-measurable disease, and IM RESIST, they actually don't, it's not used to define progression, but it has to have complete disappearance of the non-measurable disease to be a CR. But in I-RESIST and IR-RESIST, you can actually use non-measurable disease to determine unequivocal progression. So these are a little bit of nuance that is not that interesting, actually, but I just bring it up to demonstrate that there are these unique differences amongst them. Now, another thing is that, yes, clinical status is incorporated into the IR-RESIST. It has to be because, so if someone has signs of progression, either with new lesions or growth of their lesions, theoretically, a lot of the trials with immune therapy, they allow continuation of the treatment. And it's based off of a clinical judgment, whether patients tolerating treatment or if they think that there's clinical benefit or response to the treatment. So you can actually continue treatment as long as the patients are clinically stable. This clinical evaluation was not used in RESIST. The other thing is that there's confirmation of progression in the immune RESIST criteria. All of them use greater than or equal to 4 weeks. In the I-RESIST, they actually suggest that it has to occur within this 4 to 8 week window. I don't necessarily agree with that, in part because I've seen some pseudoprogressions take longer to demonstrate that this true pseudoprogression after a 2-month interval. The reason that I know why they incorporate it because if patients have progression and an alternative treatment option, they don't want them to lose the window of opportunity to move on to that second-line treatment. So they put the confirmation within this 4 to 8 week window. So again, this is just an example of some of the interpretations. So, when you are on clinical trials, usually you have, you measure the target lesion. So you have a place on the CRF forms to document target lesion measurements. And then non-target lesions are these just present or absent, that's represented by this red line. And then these stars, what's going to be new on these immune response criteria forms are the documentation of new lesions. So this is, again, a typical patient that we'd see with pseudoprogression. Again, growth of their lesion, they grew more than 20% as per RESIST, that's progressive disease. But if I RESIST, it's actually called immune unconfirmed progression of disease. Then ultimately, at the second time point, there's shrinkage of their disease, not quite meeting the threshold of 30% for a response, so that's immune stable disease. And then once it drops down to 30% or greater, that's immune partial response. Now, in this example, this patient had growth of their lesions, both non-target and target, and then a development of a new lesion. That's not confirmed progression of disease. That's solely, again, IUPD, which is immune unconfirmed progression disease. In 4 to 8 weeks, if another scan shows that there's further progression, then that would be ICPD, which would be immune confirmed progression disease. So just a few nuances with these immune resist criteria. And then, sorry, wrong way. So this second question, how common is pseudoprogression with immune checkpoint inhibitors? So very close, 20 to 29% was the top answer. But the true answer is actually less than 19%. So it's quite rare. I scoured a few trials with ipilimumab, PD-1 inhibitors, and also a variety of cancer types, melanoma, non-small cell lung cancer, renal cell, and all of them were below this 15% rate. So at least if you have someone with pseudoprogression, and you're worried that you don't know whether it's true progression, you can at least take comfort in knowing that it's rare. The other thing that I didn't present is that oftentimes patients with pseudoprogression often develop the best responses. It sort of makes sense because if you have such a brisk immune response that you're actually showing growth of your tumor, maybe your brisk immune response is so strong that also it represents a durability of response. And so if you do decide to stop treatment because they have progressive disease, you can take comfort in knowing that at least it's rare, or alternatively, they might have a good response even if you stop the treatment. So to summarize this part of the talk, immune response criteria are exploratory. Most trials use traditional response criteria for the primary endpoint, with immune-specific criteria being used as an exploratory endpoint. It remains unknown whether we can generalize amongst agents, cancer types, and cancer settings. It's tricky to know when to treat beyond progression, especially when other effective treatments are available. But for instance, in melanoma, if someone develops a complete response and they've exceeded 6 months worth of immunotherapy, theoretically there's data to suggest that it's safe to potentially stop the treatment if they've developed a complete response, because people with complete responses, the durability of response is in the order of years. Now, if they had a partial response and are tolerating treatment, I usually continue for as long as the drug is available, usually a year to 2 years. Now, it's this discordance where the pseudoprogression and discordant responses, usually if people are tolerating treatment, I actually like to continue for at least past the 4-week window up to at least 3 months. Now, it's an evolving process as well. So which immune criteria amongst the RESIST or the modified World Health immune-related response criteria is best? We don't know. Will it be contextual for particular cancers? Again, we don't know. It's unknown whether tumor markers and functional imaging will also be helpful in this setting to predict who's pseudoprogressing versus real progression. Now, this is just an example of a comparison between IM resist and its ability to predict overall survival better than normal resist. And so just looking here at these two red square boxes, this was based off of 3 studies, clinical trials using, again, atezolizumab, a PD-L1 inhibitor. So in these 2 lung studies and urothelial cancer studies, they looked at those people that progressed via the resist mechanism and via the IM resist criteria. Now, so these 2 boxes represent, so if you had progression by resist but not by IM resist, your overall survival in each of these studies was superior versus the ones that had both progression of disease via RECIST versus IM RECIST. So this sort of makes sense that IM RECIST is better at predicting overall survival and progression-free survival, because if you don't have progression by IM RECIST, then you'd expect that your overall survival would be superior. So this brings us to the last and final portion of when can we see use of immune checkpoint inhibitors in gynae cancers. You know, one, I bring up mucosal melanomas, and for you guys, it's the vaginal melanomas that typically fall into this category. The next is the mismatch repair deficient tumors, and then I'm going to talk about some other gynae malignancies. But mucosal melanomas, as you know, I'm sure all of you have seen at least a few cases, but they're quite rare, 2% of all melanomas. They typically behave more aggressively, stage per stage, compared to cutaneous melanomas. They don't have the same molecular changes because they very rarely harbor BRAF mutations, but can harbor c-KIT mutations. Immune checkpoint inhibitors have lower activity in patients with mucosal melanoma compared to their cutaneous counterparts, but the safety profile and tolerability of the immune checkpoint inhibitors is exactly the same. So this next slide looks at the efficacy and safety of PD-1 inhibition or PD-1 inhibition combined with ipilimumab in mucosal melanomas. And this just summarizes what I said exactly, is that the response rate and the median progression-free survival is inferior to that of the cutaneous counterparts. But having said that, there is still activity with mucosal melanomas with both Ipi-Nivo combination, Nivo alone, or Ipi alone. But it looks that Nivo is superior to Ipi as single agents. Now, this brings us to the mismatch repair deficient tumors. Now, this was published in the New England Journal of Medicine in 2015, and then subsequently in Science in by Dung T. Lee in last year. And you know, what I like about this study is that this is the first drug approval by the FDA based off of a purely molecular status, regardless of the type of tumor that you had. So this was all types of tumors as long as you had mismatch repair protein deficiency. And you can see the subtypes of tumors. And again, the one for your interest is the endometrial. It's a large part of this pie. Just under 20% of mismatch repair tumors were endometrial in nature. So this is, again, the waterfall plot. Again, the way to interpret this is that all these bars represent a patient. If it falls below 0, you have shrinkage of your disease. The vast majority of people with mismatch repair protein deficiency had a response. The objective response rate was 54%. The complete response rate was 21%. And not only that, is that these were heavily pretreated, and some of these tumors were very aggressive. They were pancreas cancers, cholangios, and they had to have exhausted all standard treatments. Now, what was their survival? The median survival was even more impressive. The median survival wasn't reached. The 2-year overall survival was 64%. Again, this is quite remarkable in a heavily pretreated, aggressive types of cancers survival. So this brings me to my last slide. Is there activity in other gynecological malignancies? I think there was a talk this morning on ovarian cancers, combining PD-1 inhibition with PARP inhibitors and such. But this is, again, Keynote 028 study of looking at gynae cancers of endometrial and cervical. And there was, again, these were heavily pretreated patients. Objective response rates, 13%, 17%. Median duration of response for the cervical cancer group was 5.4 months. In the endometrial group, it wasn't reached yet. Now, I just mentioned this because it was published in the Lancet, GTN, or trophoblastic neoplasms. They had a case series of 4 patients that were treated, and 3 of the 4 people that were refractory to chemotherapy. This is typically a very refractory, chemo-sensitive disease, but in those that were refractory to chemotherapy, 3 of 4 people actually had a response. Sorry, I keep going backwards here. So to conclude, immune checkpoint inhibitors have activity in a variety of gynecological malignancies. Immune checkpoint inhibitors demonstrate unique response kinetics with both delayed responses and pseudoprogression. On clinical trial, unique immune-specific response criteria are used. Immune-specific response criteria can improve progression-free survival and OS prediction, or overall survival prediction. It's tricky to know when to treat beyond progression, especially when other effective treatments are available, but that's where it's a bit of a gamble to know when to hold them and know when to fold them. And that's the end.
Thank you. So if you have any questions. Paul.
Jose, hi. I was intrigued in the couple of examples you gave when they showed progression. It looked like their drug was stopped, and yet they got excellent responses. So why do we give 18 months of checkpoint inhibitors? What's the data to say that's right for a very expensive drug? Would it be not better to give 3 months, stop, and they either do well, they do badly, or they do okay, and then it comes back and you retreat again? Sounds more cost effective. So I was wondering, where does this 18 months or 24 months, whatever it is, data actually come from? And is it real, or is it just the way the studies were done?
No, it's an excellent question. And so the duration of response in melanoma anyways, we don't really know what's the optimal duration of response. And so all of these 2 years or 18 months or a year worth of treatment is totally historical in the way that the clinical trials were designed. There is data to suggest that, again, if people develop a complete response, more often than not, those are typically durable. But in the retrospective look at that, they only looked at those that developed a complete response after they've received at least a minimum of 6 months worth of treatment. So if someone develops a complete response and have received 6 months worth of treatment, I actually debate about, yes, I think it might be safe to stop the treatment. But if they have any residual disease, we don't know what to do in that scenario. For instance, I'll give you a story I just told Teresa Petrella. I just had a patient that received 2 years worth of pembrolizumab and his disease was stable. And so we had to stop because that's how the drug's funded over 2 years. And literally by his next scan, he had a nodule in his neck that started growing. So on PET scan, it was hot, but there was some moderately hot other areas, but we decided to take him to surgery anyways because that's what he actually wanted the most. We took out his neck nodes. He had 18 lymph nodes that were all involved with melanoma. So did we have to take them out, or should we have just re-challenged him with Pembro? He actually got approved for re-challenge. There's actually data that people that had initially responded and are subsequently re-challenged after they progress off treatment, they actually respond just as well. So you're absolutely right. This duration is going to be a key question, especially in our public healthcare system. I did residency, by the way, with Paul. So.
Any other questions? Teresa?
So in terms of the duration of response, we do have a trial through CCTG looking at, in melanoma patients, what's the optimal duration of response, and patients stop treatment, are randomized to stop treatment after they've reached their maximal response. And the trial's still ongoing, so it'll be a while before we have the data, but hopefully some of that information can be extrapolated into the other tumor groups. Because if you have the option to retreat, then why treat for 2 years if you don't have to, right?
All right. Yes.
Just wanted to make one additional comment in regards to what you said on the PD-L1 inhibitors together. It's like the Nivo and the IPI in the DeAngelo study. So even though there was less or a lower response rate in comparison to the cutaneous, when they did look at the PD-L1 and hit the status in the tumors, they could see that actually in the negative ones, it was 50% or even more in all 3 of those arms. So we're looking at it for this specific patient population, it's 50% that they will respond.
Yes. Yeah, no, I didn't... The point of that slide was to say that they did have a response. There's no doubt I would want to treat them with immune therapy. So, yeah, but you're absolutely right.